Top Bed Talk.
Great pleasure to introduce another friend and colleague, Fiona Walker, who is the more glamorous half of the Walker partnership here with David, who's one of our board members. So Fiona is a cardiologist. She specialises in the care of patients with grown-up congenital heart disease, and she's here to talk about heart disease in pregnancy. Thanks, Fiona.
Thank you very much for the invite. It's lovely to be back in Dingle again. So I'm going to cover heart disease in pregnancy, which, as you can imagine, is a huge topic. So I'm going to sort of cover the scope of the problem, talk about some lesions and risk, talk about the general principles of management, and then give you some idea of outcomes. So I'm going to start off with a quiz and want a show of hands. Who thinks that a caesarean delivery is preferred for most women with heart disease? Does anyone think C-section should be done for these women? No? Okay. Who thinks that acquired heart disease is more commonly seen in pregnancy, is the most common heart disease we see? Does anyone think that's true? Acquired heart disease? No? Nobody's showing any hands. Come on. Okay. Congenital heart disease accounts for the majority of maternal deaths in the UK. Thank you. And delivery prior to 37 weeks is recommended for most of these women with heart disease. Okay, good. So I'm the head of service and have been leading the congenital heart disease service and maternal cardiology service at UCLH and Barts. We have over 10,000 adults with congenital heart disease under our follow-up, and we've had over 1,800 pregnancies to date, all with women in heart disease. So currently, heart disease complicates 2% of pregnancies. Congenital heart disease is far more common than acquired heart disease, and that's mainly due to the increased adult survivors with congenital heart disease. The complexity of heart disease is increasing, again, due to this congenital population. And of course, we're expected to be less paternalistic, and our patients are quite autonomous. So I'm just going to remind everyone in the room of the hemodynamic changes of pregnancy and its impact on the heart. It's huge. Cardiac output doubles, heart rate goes up, stroke volume goes up. And also just to point out that most of these changes don't dissipate within 24 hours of delivery. Some of them last several weeks. So women with heart disease aren't out of the woods just because the baby's been delivered. They're still at risk for several weeks after. Now, it doesn't surprise me when you see the hemodynamic changes of pregnancy that heart disease features in the maternal mortality data. In the UK, this data is being collected every 3 years. The last report was in 2016. And I suppose the good news is that direct deaths have reduced by 50% over 10 years. So that's obstetric causes. The bad news is that indirect deaths, in other words, pre-existing medical conditions, haven't changed at all in 10 years. And heart disease is the single leading cause of maternal death in the UK. So it's far more important than any of the other usual suspects that you all know about. And if you look at the maternal cardiac deaths, you will see that this pie chart is basically made up of 4 big sectors: ischemic heart disease, myocardial disease. Now, this is the inherited cardiomyopathies. Sudden cardiac death, this is a new group really due to arrhythmias, and aortic dissection. So they're the big sections. Congenital heart disease features very little in terms of maternal cardiac death. But I'll talk about congenital heart disease firstly, because this is now the commonest heart disease that you will see in pregnancy. It varies, obviously, from very simple things to very complex things, but it's the commonest birth defect. So 1% of all babies born in the UK have congenital heart disease. And, of course, they're now all going to survive to be adults. Previously, these infants died usually in their teens. Now they all survive well into adulthood and beyond. So, one word of caution about congenital heart patients. They've lived with this disease all their lives. The only thing they remember is the hole in the heart that they had closed. What they don't remember is sometimes the Fontan circulation that was created at the same time. And they look absolutely fabulous on the outside. Sadly, you need to know what's on the inside, because this patient will look like that young lady. And actually what you'll see here is this is a Fontan. This is the problem with the Fontan. This is a massive thrombus sitting in the right atrium. This is the old AP fontan, where literally this atrium is plumbed into the pulmonary artery. Very prothrombotic. They end up with giant right atria. They get clots. And this is the new streamlined version, the TCPC fontan. So this is a catheter here in the IVC and blood flowing straight up into the pulmonary arteries. But this will be on the inside of that young woman who looks really well, who's having a baby, who tells you she's got a hole in the heart. So it's the inside that counts. So a word of caution again, the majority of adults with congenital heart disease are palliated, they're not cured, and that means they need long-term follow-up, lifelong follow-up, and they need multiple interventions and surgeries over their lifetime. So if ever you come across a patient with congenital heart disease who's lost a follow-up, please try and repatriate them to a cardiac unit. They don't get discharged. We look after them forever. Now, people have tried to come up with risk scores for women with heart disease having babies. This was one of the first ones in 2001 from the Toronto group. And you'll see they had 600 pregnancies. Again, the majority had congenital heart disease, and they looked at outcomes. And they had an adverse event rate of 13%. Deaths quite low, but heart failure, arrhythmia common. This is the European study, which was around 2013. Again, this was only in patients with congenital heart disease. They found that cardiac complications occurred in 10%, but also that there was significant obstetric and fetal complications. This is the European Registry, which started in 2007, started off with only 1,300 pregnancies, and you can see this was across a broad spectrum of countries, developed and third world. And they came out with event rates of 13% for this patient population. This study is now extended and has more countries participating, around 6,000 pregnancies. And this is the diagnoses. Again, you'll note that congenital heart disease is the commonest heart disease, whereas valvular heart disease is most common in the developing world. And if you look at, again, outcomes, mortality is quite low unless you have pulmonary arterial hypertension, but complications such as heart failure and arrhythmias are common. So if you have somebody with known heart disease, it's all about prior planning. And please don't somebody ask me what the 6th P is, which I got asked once at a cardiac conference. So if you know someone's got heart disease, when patients come to see me, it's all about a workup. They have up-to-date imaging, exercise testing, look at their medications, and consider their thromboembolic risk. Functional testing, again, is really important in this patient group. They'll tell you they're asymptomatic. They'll tell you they can do anything they want. This is cardiopulmonary exercise data. You will see that even something as simple as a repaired ASD, these patients have suboptimal, submaximal performance. None of these patients have normal function following cardiac surgery. And thromboembolic risk, extremely important. This is a patient with hypertrophic cardiomyopathy who has an ICD lead in situ, and at 26 weeks has a routine echo, and there's a massive thrombus attached to the lead. Lots of our patients have hardware in their hearts, devices are more common, and so this is something that we don't want to see, but again, we've now realised most of these patients with intracardiac hardware should be anticoagulated. On detailed history, this lady reported that her sister had a PE, and actually she had one of the inherited thrombophilias and was then fully anticoagulated, but this is not what you want to see in a pregnant patient. Now, the ESC have come up with guidelines for the lesions and risk, and I'm going to flick through these. You can download them, they're free. And essentially, they're using a WHO classification. 1 is little or no risk, and 4 is extremely high risk and pregnancy contraindicated. This is the high-risk disorders, just in case you haven't seen this before. Pulmonary hypertension, severe ventricular impairment, peripartum cardiomyopathy, severe symptomatic valve disease, Marfan syndrome and bicuspid valve, and native severe coarc. After that, the lesions become less complex, therefore they're saying that the risks are less. And as you go through the whole list, it gets down to the conditions that have little or no risk of any problems in pregnancy. But guidelines are great, and I think some of our younger fellows love the guidelines, whereas, of course, you have to know what the guidelines are based on. And in pregnancy and heart disease, they're based on very little apart from consensus. So this is not a scientific tome that you must adhere to. This is just some advice from people like myself sitting around a table saying what we think is best practice. And guidelines, again, they're doing their best to try and simplify things for us. But of course, patients often don't fit into neat boxes. Pregnancy can change. Most of the obstetric complications will increase the risk of a cardiac pregnancy. And of course, we've got other layers of complexity now with all these devices that are implanted in some of our patients. So, to reiterate, congenital heart disease is more common than acquired heart disease in pregnancy. Deaths in pregnancy from acquired heart disease outnumber those from congenital. And the majority of deaths, sadly, occur in those with undiagnosed heart disease. So how are we going to improve on our maternal mortality data? I think it needs increased awareness of the problem. Any woman with known heart disease should have preconception counselling. I think it needs better history taking by anyone who comes into contact with these patients and better recognition of symptoms. And it's essentially about greater vigilance by all of us who come into contact with any woman with heart disease who's pregnant. Now, pathological symptoms are difficult because all women say they're breathless, they all have palpitations, they sometimes get edema. But if symptoms are progressive, that's of concern. If things don't go away and things worsen, that's a concern. And any sort of loud murmurs or diastolic murmurs are abnormal. Improved chest X-ray diagnosis. One of my colleagues, an obstetric physician, showed this at one of the Royal College of Anaesthesia meetings and was asking people what they thought it showed, and nobody got it right, and she went crazy because she pointed out that we would have all diagnosed this X-ray as medical students. Why can't we diagnose this X-ray now? This is just pulmonary edema, barn door, simple. The family history and past medical history is so important because if somebody has joint hypermobility, or there's a family history of early death, or there's sudden cardiac death, or there's strong risk factors for ischemic heart disease, this means if we pick these things up, we might prevent some of these aortic dissections, we might prevent sudden deaths, and we might prevent women dying from cardiomyopathy in pregnancy. Now, if somebody has a history of sudden cardiac death, just to remind everybody, the best test is an ECG. 90% of those with an inherited cardiomyopathy have an abnormal ECG. So if an ECG looks strange in a pregnant woman who has some symptoms of palpitations, this will give you some ideas. Now, these are all ECGs we showed yesterday, so the guys who came to the workshop will know what these are. This is Brugada, this is a hypertrophic cardiomyopathy, and this is long QT. So something as simple as an ECG, if you've got somebody with that history of sudden death or premature death in the family, an ECG will hopefully help pick up these inherited arrhythmias. Now, I specifically want to mention the aortopathy group and the STARS because these patients with fragile aortas and connective tissue disease have a phenotype. We can all pick these patients up by looking at them. And what do I mean by that? Well, this is the aortic media and the pregnancy effects, and essentially the hormones and estrogen make the aortic wall much weaker. So anybody with a connective tissue disorder is much more at risk of aortic dissection in pregnancy. We're all worried about these fragile aortas, these patients, because the worst thing that can happen is an acute aortic dissection. Because if that happens, and you'll see this is a dissection flap here, and on echo you can see it the same, there's a 30% mortality if somebody has an aortic dissection. And an aortic dissection in pregnancy, as you can imagine, is catastrophic. So Marfan syndrome, joint hypermobility, something very simple to ask patients if they're hypermobile. And they have a phenotype. They have a high arch palate. They have arachnodactyly, which means they can do good tricks with their hands and fingers. And this is dural-ectasia. The reason I mention this, if there's any obstetric anaesthetists in the room, if you have dural-ectasia, there's a huge sac around the bottom of the spinal cord. It means your dose of epidural needs to be massive because it all pools at the bottom there. So that's just a note about epidurals. Now, Loeys-Dietz is another horrible condition, similar to Marfan overlap, and they have a bifid uvula. So if you look in their mouth, you would pick up that this patient has something going on that's abnormal. And it's just worth knowing that patients with Marfan syndrome aren't always 6 foot tall with long arms. There's lots of different phenotypes in terms of the musculoskeletal changes they have. Again, this condition is terrible. They end up with aneurysms in many blood vessels. The median age of death is 28 years. Vascular Ehlers-Danlos, they have a phenotype. They have blue sclera, they have stretchy skin, they get abnormal stretch marks. And again, simple thing, they're hypermobile. So hypermobility is a sign of connective tissue disease, not always something that's malignant, can be quite benign, but it's worth looking for these other features. And Turner's syndrome, a new group coming through. Not all of them need IVF, but they are coming through and having pregnancies with IVF. But if you note, their aortic dissection rate is really huge compared to the normal population. So again, a group that are significantly at risk in pregnancy. Now, all the women in the confidential inquiry report who died from ischemic heart disease had strong risk factors for ischemic heart disease. So this is just a reminder that ischemic heart disease and myocardial infarction isn't that rare. If you see, there's a 4-fold increase in acute myocardial infarct since 2002 in women, and 10% of women who have an acute MI are less than 35 years of age. And nowadays, it's atherosclerotic disease that's the main cause of ischemia and infarction. You can treat them with the usual drugs, and if you do see somebody in pregnancy who's having an infarct, coronary angioplasty and stenting is the treatment modality of choice. Now, it's all to me about organisation of antenatal care. These high-risk groups and women really need to be seen in specialist centres and high-volume centres, and then their care is stratified based on the risk and lesions. This is the model we have at UCLH. So some women come into the specialist centre only. We have shared care with some district general hospitals, cardiologists and obstetricians, and obviously patients can move between the different levels of care based on their need and if there's any complications. You do need level 3 NICU and level 3 ITU if you're going to have a pregnancy practice that looks after these sort of patients. And of course, that's not without cost and infrastructure and the personnel that need to be funded to run this sort of service. Just one comment on delivery. This is the C-section rates from that European registry, and you'll see that lots of these women with heart disease are having caesarean sections. And that's despite the fact that it's known that elective section confers no benefit in terms of maternal outcome for these women. All it does is mean you tend to deliver babies earlier and there's reduced birth weight of the infants. In UCLH, we hardly ever deliver anyone by C-section. Most of these women have normal deliveries, except for anticoagulated mechanical valves, the fragile aortas, and patients in acute heart failure. There's a plan for all these patients that's in the patient's notes. It's given to the GP and it goes on the electronic record in the hospital. And for those patients with complex congenital heart disease, we draw a picture so everybody knows which way the blood goes round. Now, I don't say much about uterotonics because my anaesthetist, Rory Bell, is the person that advises about uterotonics. I give him the physiology and the cardiac problem, and actually this is just a comment he made to somebody who was asking for advice, so I thought I'd put that in. Misoprostol they use all the time. Now, in terms of intrapartum monitoring, the good news is we rarely do anything significant. Most of these women are on labour ward. They go back to the postnatal ward with a few exceptions. And it's really only those women with very complex disease that have to go and have lines put in or go to ITU. Mainly, it's all about fluid balance management in these patients. Now, this is our cumulative numbers of pregnancies, and it's actually now gone up to 1,800 of the last year. And again, you'll see our practice is similar. It's mainly congenital heart disease, but we also see inherited and acquired heart disease. 60% is either highly complex or moderately complex lesions based on that WHO score. And this is highly complex, and I hope you'll all agree. It's basically patients with Fontans, cyanotic patients, impaired ventricles, mechanical valves. So the complexity in our group is quite significant. And yet, our outcomes are really good. I think there's a team that's been looking after these sort of patients for 15 years. It's consultant delivered, and you'll see that we only had a 5% complication rate in our practice, and that's of all of those 1,800 pregnancies. The 2 deaths, one was an aortic dissection, which is unpredictable no matter what you do, and the other one was an obstetric death, not a cardiac death. So we're pretty pleased with our outcome data. That's the end of my talk, but I always feel I should thank labour ward anaesthetists, if there are any here, because I know it's them in the middle of the night that are really caring for my patients. Thank you very much.
Stop that, please.